Thoracic trauma is the second leading cause of all traumatic deaths, and 25% of all traumatic deaths are from trauma. It's very unusual to have just isolated thoracic trauma. It's very uncommon. So what you need to do is look for associated injuries if somebody comes in with that kind of a mechanism or those types of injuries. Some of the types of traumatic injuries that you'll see, I'm sure you've heard these classifications before. There's penetrating and blunt. Penetrating injuries include gunshot wounds, stab wounds, and basically impalement types of things. Somebody fell off the roof onto an iron fence and, you know, it's got something where it doesn't belong. Blunt trauma is also classified as in different types. There's rapid deceleration, which is VAs or falls, motorcycle accidents, those sorts of things. Direct impact. We've had people come in who've, you know, baseball players who got hit in the chest with a baseball at high speed. You know, those can cause some thoracic injuries. And also compression injuries, which are basically crush injuries. Those are a lot of workplace type things. Somebody got behind a truck when they shouldn't have, and it backed them into a wall and crushed their chest. And those all things have happened before. Okay. So we're going to talk about rib fractures first, and what you're going to do, obviously, is your physical assessment when you see somebody with rib fractures. The presence of pain, of course, is going to be a big one for these patients. Presence of subcutaneous emphysema and crepitus. Do you guys know the difference between the two? What's sub-Q emphysema? Anybody? Right, the Rice Krispie feel, that's air in the subcutaneous tissue, so leakage of air from somewhere in the airways or lungs. And then crepitus. What's crepitus? That's more of a fracture type feeling. If you have rib fractures or any bony fracture actually, and you can feel kind of a crackling feeling under the skin at the site of a fracture, that's crepitus. So crepitus is a bony thing, and emphysema, sub-Q emphysema, is an air in the wrong place. They can have involuntary splinting as well. It's pretty common. And you're going to want to monitor their O2 saturations, ABGs, serial studies as far as that goes. And what are we looking for as far as O2 sats? Anybody know what's kind of a cutoff as to what we need to notify the docs and be concerned about? 92. 92 is usually the way they write the orders. Call if saturation drops below 92, and that's pretty typical. But if you start seeing trending down, somebody's got a normal sat on just minimal oxygen or room air, and they start trending down, that's the time to notify the providers, because you want to make sure that you take care of whatever's going on before it gets worse. Okay, so some things that we see with rib fractures. So if you have a fracture of ribs 1 through 4, those are protected anatomically by the clavicle, right? And so it takes a lot of force to injure those. So you're going to look for associated injuries. Do you guys have any idea what might be underlying those ribs that might be a problem if they're fractured? Think of something that arches up and goes down. The aorta, great vessels, aorta, head and spinal cord as well, because if you have force enough to fracture your first or second rib, you could also have a neck injury or head injury as well. Ribs 5 through 9 are the most frequently fractured, and they're associated with your typical Pneumothoraces, and also pulmonary contusions. And then ribs 10 through 12 are not fractured terribly often, just because they're much more mobile. They're not tethered as securely as the uppers, but they are associated with abdominal injuries, mostly spleen and liver. So if you have some lower rib fractures, you might want to take an extra look at that abdominal ultrasound that they do in trauma and make sure that there's no fluid in any areas. Okay, so if we have an elderly person that has rib fractures, they're of course going to be more prone to morbidity for any kind of injury, and we're seeing so many more elderly people in the trauma unit. So 50% of people that are elderly and have rib fractures will have a significant morbidity. So you really need to be on top of their pulmonary toilet, mobility, getting them out of bed, that kind of thing, pain control. Flail chest is obviously another type of rib fracture scenario, and it's considered 2 or more ribs fractured in 2 or more places, causing a free floating segment. So when you have somebody that is spontaneously breathing, you'll see a paradoxical motion of the chest wall in that area. It's also if they have a free floating sternum. If the ribs are separated from the sternum by an injury without actual fractures of the ribs, then that's also considered flail. So what you don't want to do is wrap or tape the chest. That was an old treatment many years ago. Probably haven't done that in, 30 or 40 years. But that restricts, obviously, chest expansion, and what you want to make sure the patient's able to do is breathe fully. Avoid intubation if possible, just because it just makes it hard to wean the patient, especially in the elderly. But if they do need internal stabilization, the best thing to do is positive pressure ventilation. And that's most often achieved with intubation. Can you think of another way we can do positive pressure ventilation without intubating somebody? BiPAP. Yep. I don't know how well it works to stabilize rib fractures, but what it will help do is keep the alveoli open and the lungs expanded. That helps. Okay, so the biggest thing is to assess and manage the pain. So you want to manage pain control with not too much sedation or sleepiness, because they're too sleepy, they're not going to breathe. But you want them to be able to have pain relief so that they can take deep breaths and use their IS and that sort of thing. So pulmonary toilet is the utmost importance for these patients. They do supervised IS generally. At the beginning, they do coughing and deep breathing, give them a pillow to splint if it helps them. And also we'll have RT do weaning parameters. They'll do the maximum inspiratory pressure and vital capacity, usually twice a day on these patients, and trend their results and make sure that they're not getting tired or diminishing their lung capacity as they're here in the hospital. And also get them up and out of bed as soon as you can after their spine's cleared. Okay, now, tension, pneumo, and hemothoraces, those are obviously life-threatening injuries. What happens is air or blood is in the wrong place at the wrong time. Well, I always think if there's air or blood in the wrong place, it's always the wrong time, right? It should never be where it's not supposed to be. So what happens is air is trapped in the pleural space or blood, which leads to a shift in the mediastinum that compresses the heart and great vessels, the trachea, and the uninjured lung. Everything from the point of pressure gets shoved over to the other side. And what happens with that is you have impaired venous return, basically, which decreases your cardiac output, which will cause hypotension. And that's where the emergency is with this, is they will have cardiac failure if it's severe enough. So some of the things that you'll see in a patient with attention, pneumothorax, severe respiratory distress. I mean, like crazy, really, freaking out that they can't breathe, kind of respiratory distress. They have decreased or absent breath sounds on the affected side. Distended neck veins. This is, of course, one of the symptoms of it, but, if you have a patient that's in a collar, laying flat, a lot of people have distended neck veins. When you check for an assessment of somebody's neck veins, it's usually at a 45-degree angle. And a lot of our trauma patients are not allowed to be sitting up that high at the outset, so I wouldn't rely on that, but you could see that. You'll also have, obviously, decreased O2 saturation, increased PIPs if they're on the ventilator, hypotension, increased heart rate, all the typical things that you'll see with circulatory collapse. Deviated trachea, again, toward the uninjured side. I actually have seen that on trauma patients once or twice, but not consistently. There's been more patients that I've seen with attention pneumo that have not had anything other than severe respiratory distress and dropping SATs and dropping blood pressure. And they can also have cyanosis, which is a late sign. You don't want to wait for that. And they also, what's another thing that you think you'll see with a patient who's severely in respiratory distress? In their behavior, you think? They're going to be really agitated, like crazy agitated, especially if they're normal before, there's no issues with a head injury or anything like that, and they suddenly get completely antsy and all that. You're going to want to check and see what's going on. Okay, so what are this? It's obviously an emergency, and you need the docs to get down there right quick and do a needle thoracentesis. Usually what they use is a 14 gauge, 2-inch long IV catheter, and they just insert it into the second intercostal space, mid line, the fifth axillary line. Those are the two typical spots. Is that a definitive treatment? After they do that and they've expanded the lung, the patient's looking better, they just make the lot go away. No, it's a chest tube. Just to make sure that this doesn't recur. Or they can, get the rest of the blood out, whatever, if it's a hemothorax. You also want to open up the fluids, give them some circulatory support, and then, of course, prepare for your chest tube insertion. So what do you need for that? You need your Pleurovac, you need your chest tube. And what we do down in the SICU is we use a resus tray, which is a sterile tray that we get from sterile processing that has all the little instruments and stuff in it that they use. I don't know what you guys would use upstairs if you have like a special tray for that, or the docs sometimes will just run down and borrow one of our trays, which we kind of like to discourage them from doing that, but in an emergency. And then also make sure that they have blood available. If it's a hemothorax, they're going to need to replace that blood at some point, so make sure that they've got their clot to the lab and talk to the docs about ordering blood if they think it's necessary. If it's a massive hemothorax, and massive hemothorax is considered a rapid accumulation of 1.5 liters of blood in the chest, in the pleural space. So if they have that type of blood accumulation, then they're going to need to go to the OR. And a lot of times that's can be due to a laceration of the intercostal artery, that suddenly you just get this massive dumping of blood into the pleural space. So they need to go to the OR and fix that. Any questions about that? Okay. Pulmonary contusions. Again, your assessment. Pulmonary contusions are not terribly evident right away. You see them in the next day or two on the chest x-ray. When they talk about a blossoming contusion, it'll look like some infiltrates that they call them on the x-ray. So it's usually a couple of days after the initial resus that we'll start seeing that. It can be insidious development because of just gradual edema to the damaged tissue in the lungs. Could possibly require intubation if their respiratory distress is severe enough. You want to make sure that if they are ventilated that we keep an eye on their peak pressures, because they're going to have decreased compliance because of the lung injury. And also if they have a pulmonary history, they'll be more compromised with pulmonary contusions. So you want to be careful with giving them IV fluids. If you overload them with too much IV fluid, they will increase their pulmonary edema. Sometimes they will give them a couple doses of Lasix if they seem to be having some pulmonary edema issues. You want to make sure that you follow serial ABGs, your O2 sats, breath sounds, work of breathing, all those things that you would normally do on your lung assessments. And then sometimes they'll have pink or bloody secretions. And again, follow peak pressures if they are intubated, because they could have risk for barrel trauma with their decreased compliance. Okay. So ICU Pneumothoraces, or I guess you could just say iatrogenic pneumothoraces. They can be, a lot of times they'll be caused by central line placement. We've all probably seen that happen. So you just need to make sure that they get that chest x-ray after a line is placed, a central line is placed, and it's not used before they do the read. You can also have a post-intubation pneumothorax if a patient who has very non-compliant lungs, and suddenly you get these positive pressure ventilations. They could cause a pneumothorax. And then also blunt chest trauma with or without rib fractures obviously will cause a pneumothorax as well. They could also convert to a tension pneumothorax with positive pressure ventilation. If the air is going in through a laceration in the lung into the pleural space without any route of escape, then it will just continue to accumulate with the positive pressure ventilation, and that's obviously another emergency happening there. Okay, cardiac injury, blunt cardiac trauma. This is kind of one of those nebulous sorts of injuries. It's not well documented during like trauma resusc or with the studies and stuff. Sometimes you will see some things on their EKG, but what you really want to do is just mostly do monitoring and look for cardiac issues based on what their mechanism of injury is. And this is mostly associated with motor vehicle accidents when patients, they don't have airbags or they're not wearing their seatbelt and their chest impacts the steering wheel. So you're going to see, look for chest wall ecchymosis or chest pain. Sometimes you'll see arrhythmias, sometimes you won't. Usually if you do, there'll be PVCs or AV blocks. These are the kind of patients who, from trauma resusc, will maybe send up to a telemetry monitoring area so that they can have some cardiac monitoring. And you want to be alert to ST and T wave changes as well. We'll do serial EKGs, 12 leads, and then cardiac enzymes, especially troponins, looking for any muscle damage. If anybody has, any kind of trauma and they have significant muscle impact, if you do just your basic CPKs, everybody's going to have an elevated CPK if they're in a car wreck and they hit the steering wheel, whether or not it's actual cardiac damage. So you want to get those cardiac specific studies as well. Okay, tamponade. Cardiac tamponade is defined as a collection of blood in the pericardial sac which inhibits ventricular filling. If it occurs acutely, it can be a life-threatening injury. So, but it can occur anytime during ICU stay because sometimes the blood accumulates slowly, sometimes it's, if there's a laceration of some sort to a coronary artery, it could occur really quickly. So it's usually associated with penetrating trauma, stab wounds in particular, but it also can happen with some blunt trauma and rib fractures. So you want to do your assessment. You want to check the result of the echo. Sometimes what they'll do when they do a FAST is they'll look at the cardiac silhouette as well, but they won't do a full cardiac echo. If they do suspect some cardiac trauma, then they'll get a cardiac echo as well. The patient will also have dyspnea, cyanosis, and Beck's triad, which is the distended neck veins, hypotension, and muffled heart tones. Again, these things are really hard to assess in the resusc room. Muffled heart tones, it's so noisy in there that, it's hard to hear that in any kind of ICU setting as well. Distended neck veins, again, if the patient's laying flat, they'll either be distended or they won't be because of hypovolemia, so they're not terribly reliable. You'll see signs of shock as well because you'll have blood filling, pericardial sac will inhibit ventricular filling and you'll have hypotension related to that. And you can also see progressive decreased voltage of ECG complexes. Again, that's kind of subtle and you have to be kind of looking for that. Okay. So what's the intervention? You can do a bedside pericardiocentesis if it's a true emergency. And what they use is an 18 gauge, 5 1/4 inch long needle. They'll insert that below or along the xiphoid process and at an angle up toward the left shoulder. I've actually never seen them do that in trauma. They always take them to the OR and do a window because if they do in fact do that, either in your patient's room or whatever in the resusc room, if the blood that comes out is not clotting, then they probably are in the pericardial sac because the motion of the heart pumping causes defibrillation of the blood around inside the pericardial sac, so it won't clot. If you actually get blood that's clots pretty quickly, then they may have punctured the cardiac wall and you're getting ventricular blood. And that's not a good thing either. So generally they'll just hop on over to the OR and get a pericardial blood. Okay. Aortic injuries. Any questions about the tamponade or? Okay. Aortic injuries, there's a little, I gave you guys all a little sheet that just a drawing of an aorta. And it shows the most common sites of aortic rupture. The most common site is, I think it's B on, A on your sheet there. It's distal to the left subclavian artery at the level of the ligamentum arteriosum. So does anybody know why that's the most common spot for your aorta to be ruptured? And we're talking usually acceleration, deceleration injuries. Fall from a big height, motorcycle accidents, I've seen it in that, motor vehicle accidents. There is. The ligamentum arteriosum is actually attaches the aortic arch to the pulmonary artery. And it's actually an old vestige of fetal circulation. And that's just where the aorta is fixed there. So there's less mobility. So what tears is the aorta and not the ligament when there's a rapid deceleration. And then, of course, if it's a rupture, it requires surgical intervention. That's, of course, if they are alive and they get to you and maintain, that way before they get to the OR. There's a very high mortality rate with ruptured aortas. If it's ruptured in the ascending aorta, they pretty much, don't live. Those are the dead at the scene kind of patients with blunt trauma. If it's a descending aortic rupture, they have some references cite an 85% mortality rate before they get to the hospital. And then you have a pretty high mortality rate in the hospital before they get to the OR. So it's not a good thing to have. So what you want to do is make sure that they have blood pressure control. In the resusc room, they will try not to push a lot of fluids because what they don't want to do is get a big head of steam in that aortic arch and blow off a clot if it happens to have been clotted. You want to keep the blood pressure nice and even. So they'll use nitrite, keep the patient quiet and calm and all that if possible. And then an arterial line to closely monitor the blood pressure. If the patient also has an associated head injury, then that makes it a little more complicated because they don't like to use nitrite in head injured patients. So sometimes they'll use esmolol or some other drug to control the pressure. Because nitrite is a big vasodilator and that's not good for head injuries. Also, if they have other associated traumas, they're going to be wanting to use anticoagulants on these patients after surgery, and that's generally not a good thing with a lot of trauma patients as well. So it's a little tricky to take care of these patients. And again, post-op, control the blood pressure, use nitrite if it's indicated. For complications that you might see post-op, why would you want to ask anesthesia what the cross-clamp time is? Right, distal organ perfusion. So you can have some complications that include paralysis, spinal cord ischemia. You can have bowel ischemia, so you're going to, check your bowel sounds, look for fever, abdominal pain, distension. Renal ischemia is fairly common. They may have to get a little run of dialysis sometimes if they've had a long cross-clamp time. And also there's a possibility of graft leak or infection. You're going to watch your chest tube output to make sure there's no leaking. And also if there's a fever that's not explained, then they might be looking at the infection of the graft.
What's the average cross-clamp time?
I guess it depends on how severe the tear is, and what kind of repair they have to do. So I don't know. Dana, do you have any idea? Average cross-clamp time for aortic repair?
No,
I don't know if it's
I really don't. But
30 minutes or something like that.
They usually aim for 30 minutes.
Yeah.
If it's a scheduled thing, like a
Right.
AAA, when
Yeah.
it's a controlled, but when you're talking about a trauma patient and it's an
I have no
uncontrolled
idea.
thing, it's, whatever they can
Yeah.
manage, but they certainly try to limit it.
And they're doing a lot more aortic repairs endovascularly now, so they're going
Yeah.
to IR port, which is great.
Yes.
So you don't even have to worry about that.
thoracic is easier.
Okay, so just any questions about that? We're kind of done with the injury things. I was going to talk a little bit about chest tubes. So we use a lot of chest tubes in thoracic trauma, obviously, for their, different things. What you want to make sure is that the chest tubes are banded. We have a couple in the S side. I don't know, do you guys have one upstairs, the banding gun? There's a rundown of RORs. Hopefully they'll come with it. Yeah. Those are actually the most secure way to, make sure your connections are stable. Tape, we used to use that a long time ago. I know some places still do that. If you have a patient that comes from another hospital or something, they've got tape on the chest tube, that needs to be fixed because that's not a secure, airtight connection. And you also want to make sure there's no clamps on the drainage tube. So here's our little Plurvac. They all come with a clamp on it. I don't know why, but they really should not be used. So this, either take it off completely or just make sure that it's always free and open. Okay. So you want to make sure that you have the appropriate fluid levels in the chambers. Right, this one I just pulled out of a, I didn't actually just fill this, it's been sitting there for a while. So the fluid level for the chest tube is at 20 centimeters, right, of water. So this is where you fill it to here in the suction control chamber, and the fluid level here where the little blue line is in the water seal chamber. So just make sure those are, because if you've had a patient that's had a chest tube for a few days and it's on pretty vigorous bubbling, the suction, sometimes the water will evaporate in the chambers, and you want to make sure that that's okay. Okay, and what else do we have? You also want to make sure that there's an occlusive petroleum dressing, petroleum gauze at the site. You could have, if you're looking for air leaks in your system and there's a persistent air leak that's not explained by the patient still having a pneumo, then you want to make sure that you check all your connections. And one of the things to check is at the dressing at the site. If you've got a piece of Vaseline gauze that is, dry as a bone, and not adhering to the skin, you want to change that and make sure that it's occluding the insertion site. And make sure, obviously, if the patient's going anywhere, that the Plurvac goes along with them. Had those things get kicked over, knocked over, all that stuff. So you just want to make sure that it doesn't get pulled out. Okay, a couple of things that you can see with chest tubes. If you have constant bubbling in the water seal chamber when it is on suction, so that's a little chamber, right? Water seal is this. If you have constant bubbling in that chamber when the patient's on suction, what does that mean? There's an air leak, right? So if the patient has a chest tube for a brand new pneumothorax, would you expect to see water bubbling in there? You'd see water bubbling as long as they have air that you're pulling out, right? Or do you see the water in here? Where do you see the bubbling for that? Oh, is that too close? Sorry. Oh, okay. So, yeah, if you have an air leak, you'll see bubbling in the small chamber, right? Okay. And then, where's my next one? Suction control chamber, should that be bubbling? If it's on suction, right? So if it's not bubbling and your order says to be on, it's supposed to be on 20 centimeters of water suction, then what do you need to do? Right, did it come disconnected? Do you have, something is not right with your system. If it's connected, also these things have little valves at the end of it. This one has been off. These things here should also, these can open and close, but they should also always be open. I know some of the literature that comes with this says that you can adjust the level of the bubbling with this, but that's not really recommended that you do that, because if it flips off, then you're not going to get any suction at all. So we should leave that open all the time. Okay, if the patient is off suction, there's no movement in the fluid column or the water seal chamber. What could that indicate? Right, you should have tiling. Right, there could be either a kink in the tube, something's occluded, something's not right. You should see some fluctuation in the water seal chamber with respirations, right? Yeah. Okay, what if the doc says increase the suction to 40 centimeters of water?
You need the dry one.
Right, exactly. Yeah, I mean, if you actually, I was looking at the literature that comes with this in the packaging, and it says there's some way that you can actually manipulate this to do that, but we don't do that either. You know, you have to occlude some port, and then you have to fiddle with the wall suction. That's not something that we do here. So if they want more suction for some reason, it should be very unusual, I would think, that you need to get one of the dry, what are they called? What are the dry ones called, Dana? I forget now. Oasis, yes, where they have a dial up here, and you can dial whatever centimeter water suction that the physician orders. If it's just 20 centimeters, then we use this. Okay. In the water seal chamber, right? Yes.
We've had patients come back with that are dry.
Completely dry, with nothing in it at all. Yeah. Yeah. Okay. Okay. So, what would you do if you look down and notice a continuous column of blood from a patient's chest to the pleurovac?
New onset?
What's that?
New onset, or has it been doing it since it was put in?
Either way, new onset, you know, you're going to wait. You will, if you have a hemothorax and they insert the chest tube, you're going to see, you know, wait for that column of blood to finish, and then you do your initial.
Notify the doctor. You want to check your age.
Right. Check your blood pressure, vital signs. Just do an assessment of the patient. See what's going on. If they, you know, maybe you've turned the patient and they just dumped a pocket of blood from an area. At some point, that should, you know, resolve and stop. But if you see just a continuous column, then there may be, you know, additional bleeding going on. They could have, you know, have an intercostal artery bleeder that wasn't caught somehow. That they may need to go to the OR to have that fixed. Okay, so patient's had a lot of drainage, but now it's suddenly stopped, and the patient's complaining of difficulty breathing.
Check your suction, check your system.
Okay, right. So they could have also a dislodged tube possibly, and you could have more accumulation of blood in the pleural space that's not being drained. You could have a clot within the tube itself if it's, you know, hemothorax. What would you do if you see like a clot in the tube?